Praveen shared the screen. Yeah.
Shall I start, sir?
Yeah.
A 69 years old female came with complaints of swelling in the front of the neck since 6 months. Patient was apparently normal 6 months back. Then she noticed swelling in the front of the neck, insidious in onset, progressively increasing in size, has attained double the initial size at present. Initially, it was painless and pain was started post biopsy. No history of difficulty in breathing or swallowing, no history of change in voice, no features suggestive of hypothyroidism or hyperthyroidism, no history of loss of weight or appetite.
Here, when you tell size, you should mention some size. I can't, with this history, I can't imagine what is the size of the swelling and how it was and how big it is. Correct? The swelling, that's what is see. Well, swelling in front of the neck. What is the size?
ಸುಭಾಷ್ ಏನಂದ್ರೆ ಇವರು ಎಕ್ಸಾಮಿನರ್ಸು they don't expect you because see, the patient will not be able to measure it or anything. They may,
They have
if
to give
anybody
something
cites
like
lemon
peanut
size
size, a marble
ಆ
size. Now
ಥರನೇ
he's telling
ಹೇಳಿದ್ರೆ
lemon
ಸರಿ.
size, something like that.
ಅವ್ರು ಏನಾದ್ರು ಹೇಳಿದ್ರೆ ಸರಿ, ಇಲ್ಲ ಅಂದ್ರೆ this is acceptable. That it started slowly, it has doubled the size, approximately doubled the size. But when you examine, you can definitively tell the size of the swelling. The patient has said something.
Initially noted the size of swelling of peanut, now it gradually increases lemon answer ಬಂದ್ಬಿಡೋದು or 1 into 1 into 3 into 5 centimeters.
ಅಲ್ಲ ಬಟ್ ಅವ್ರ ಪೇಷಂಟ್ ಎಕ್ಸಾಮಿನ್ ಮಾಡಿರಲ್ವಲ್ಲ ಸೈಜ್ ಅವ್ರೇನು ನೋಡ್ಕೊಳ್ತಾರಲ್ಲ.
What patient was here? According to our history, I have noted a small swelling which is of size of a peanut. Now it has increased gradually to the size of this one. Uneducated ಆದರೆ educated ಆದರೆ 1 into 1 or now it is increased to 6 centimeters. That is accepted because patient can tell how big, what was the swelling size and how big the swelling is increased now. Okay, whatever you thought. Next.
Yeah.
Patient is a known case of type 2 diabetes mellitus and hypertension on medication. She had undergone C-section in 1971 and 1981, followed by open appendicectomy in 1977 and hysterectomy in 1990. No history of exposure to radiation during childhood to head and neck and chest. Patient takes vegetarian diet, has normal sleep pattern, has normal bowel and bladder habits, no history of smoking or alcohol intake, no history of similar illness in family members, and no history of thyroid malignancy in the family.
Okay, summarize the history.
So, a 69 years old type 2 diabetic and hypertensive female presented with swelling in the front of the neck with no pressure symptoms and in euthyroid status.
Okay. Anybody, any questions? Nitya?
No, sir.
Nikita?
Everybody.
Ainas? Anybody? I don't want to call out everybody. If there is any questions, please ask now.
Should we comment mandatorily on the menstrual history, sir?
He's post-menopausal, no? So I don't think it is relevant now. Okay. Unless there was anything very significant. If you are talking about, CA cervix or CA endometrium, then you need to tell that. But otherwise, I don't think now it is relevant. He's already post-menopausal, right? This is 69-year-old.
Yes, sir.
Okay, I don't think you need to mention that. Okay, carry on. Examination.
On general and physical examination, patient was conscious oriented, moderately built and nourished. No pallor, no icterus, no sinuses, no clubbing, no pedal edema, no generalized lymphadenopathy, no eye signs. Vitals, pulse rate 78 beats per minute, regular in rhythm, normal volume and character. BP 130/70 mm of Hg, saturation 98% on room and afebrile. Examination of neck. After getting informed verbal consent, patient was exposed adequately in a well-lit room with a female attendant in sitting position. On inspection, a 4x4 centimeter swelling in front of the neck in thyroid region, which was smooth in surface, and swelling moves with deglutition, not moving with protrusion of tongue. Skin discoloration was noted at the biopsy site. No other skin changes noted. No dilated veins over the neck and chest wall. No other swellings visible over the neck. On palpation, no local rise of temperature, no tenderness. A solitary swelling of 4x4 centimeters over right thyroid region, smooth surface, hard in consistency with well-defined margins, extending superiorly till thyroid cartilage. Inferiorly 1 centimeter above suprasternal notch, laterally laterally till 2 centimeters from anterior border of sternocleidomastoid, with no tracheal deviation. Carotid pulsations are felt, no palpable 3, no palpable cervical lymph nodes, and pembetasines negative, with no BROE. On systemic examination, CVS, S1, S2 had no murmurs. Respiratory system, bilateral normal vascular blood sounds per head. CNS, no focal neurological deficits. GAT, abdomen was soft, no organomegaly. To summarize, a 69-year-old woman with diabetes and hypertension presented painless, progressively increasing for plus 4 centimeter thyroid swelling with no pressure symptoms with euthyroid status in 6 months. And my differential diagnosis would be of first will be of non-toxic solitary nodular goiter. Second would be of carcinoma of thyroid.
Is there only one nodule that you could palpate? The whole thing 4 into 4 centimeter, one nodule?
One, yes, sir. One swelling. Sir.
The left gland, left lobe of thyroid not palpable?
Not palpable. Not palpable.
At all?
Yes, sir.
Not enlarged at all?
No, sir.
Even if it is enlarged, that means it's a multinodular goiter. You know that, no?
Yes, sir. Yes, sir.
Okay. So the left lobe of the thyroid is not palpable at all?
Yes, sir.
And no tracheal deviation?
No, sir.
Okay. I have not examined this patient. Who has examined this patient apart from before Subhash, because Subhash would have examined. Before Subhash comes in, anybody, our residents, registrars, junior consultant? Speak up. Do you agree with all the findings that whoever has examined?
Yes, sir.
You don't have to be, diffident. If we are agreeing with the findings, you will just say so.
Yes, sir.
So,
I agree with the findings.
so hard in consistency.
Yes, sir.
Firm to hard it was, sir.
Subhash,
Yes, sir. From to hard.
you agree with the differential diagnosis, non-toxic solitary nodule?
Hmm.
Because at this age,
Hmm.
solitary nodule goiter is quite rare at 69 years of age. I would reverse the differential diagnosis. First put carcinoma of thyroid, then go for the this one,
Sir,
solitary.
order. Okay. Order fine. Okay. It was more of right lobe and isthmus.
Okay, right. Now, how would you proceed with the investigations in this patient?
First, to confirm the diagnosis, to assess the to stage the disease and to assess the patient fitness, we'll be doing the test. So, to confirm the diagnosis, we'll do the ultrasonography followed by FNAC and thyroid profile.
I would first say thyroid profile and then ultrasound and ultrasound guided FNAC.
Yes.
Okay, so what are the features you expect in ultrasound to go with your diagnosis? Praveen.
So,
What if it's a solitary nodule? What if it's carcinoma of thyroid? What will ultrasound tell you?
It can distinguish between if it is solid or a cystic lesion, sir. It
No,
is
no,
both
I
solid
want you
and
to tell me if it is a solitary nodule, what would you find? I want you to tell me what would you find if it's a carcinoma of thyroid based on the ultrasound findings. Nikita?
Sir, first thing would be about it's all about the thyroid score, sir. The composition,
Yeah.
shape, and echogenicity, sir. If it is a solitary nodule, it would be either spongiform or cystic consistency. And if it is a malignancy, it would be solid composition most of the cases. And
Or
in
mixed
sir,
with hypoechoic with mixed echogenicity
mix and
with the solitary, the liquid, cystic and solid component.
yes, sir. And smooth margins and defined margins would be for the nodule, whereas for the malignancy, it would be ill-defined and irregular margins.
Yeah. Nodule will
Microscopic
be
applications.
taller than wider, will
Is
go in
malignancy.
favor of a malignancy. Wider than taller will be going in the favor of a solitary nodule.
Yes.
Okay. Then presence of calcification
microcalcifications.
and rim calcification. Rim calcification, does it suggest anything? It may be just a long-standing nodule. It may not necessarily indicate malignancy, but as you said, microcalcification will usually suggestive of malignancy. And then what else? What about vascularity? What happens to vascularity? Clinically, it is euthyroid. Patient has no symptoms of hyperthyroidism. So, if it is hypervascular, it goes in favor of
Malignancy.
That means that there are neovascularization due to malignancy.
Neovascularization has started.
Yeah. So vascularity. Then again, presence of lymph nodes. So if there are multiple lymph nodes in the neck, though they are clinically not palpable, and then again lymph node characteristics, which again are classical in case of malignancy, you would not expect multiple lymph nodes in a patient with solitary nodule, but you would expect nodes maybe if it is malignancy. So all of these features indicate that it may be either solitary nodule or malignancy. Then you do a ultrasound guided FNAC of the region most suspicious of malignancy if you are suspecting malignancy. Okay, what did the some picture show? Put up the ultrasound report.
Sir, Niranjan here. I just want to add one this thing. Usually in thyroid, generally in exams they say either you stick to firm or you stick to hardness, and there is only one hard swelling in thyroid, which is anaplastic carcinoma.
Yeah.
Rest of them will be usually firm. So if you say firm to hard, I think you will end up in unnecessarily creating a controversy there and landing up in trouble. So either you stick to firm or you stick to hard. What is your opinion? Firm to hard.
I think you're right. Subhash?
Yes, sir.
Firm to hard ಅಂತ ಹೇಳ್ಬೋದಾ ಅಥವಾ ಬರೀ firm ಅಂತ ಹೇಳೋದಾ ಏನು?
It was more in the isthmus.
Ah.
And it was stretched, alwa. So it was firm to hard. If it is in the lobes, you can tell it as firm. It was more stretched here and sitting on the isthmus. It was looking to firm to hard.
Okay. Okay, put up the ultrasound report and FNAC report.
Sir, ultrasound showed a heteroechoic lobulated lesion with areas of echogenic focus and calcification involving right lobe of thyroid 5 lesion. FNAC is suggestive of papillary carcinoma of thyroid.
Okay. And ultrasound didn't show any other small micro because multicentricity, multifocality, nothing like that?
No, sir.
No other calcification elsewhere in the other left lobe was normal?
Yes, sir. Only right
Okay.
lobe normal.
Okay. What about the thyroid functions? T3, T4,
Normal,
T6?
sir.
Normal. Okay.
Yes, sir.
So with this, the diagnosis is papillary
Papillary
carcinoma thyroid.
carcinoma of thyroid. Yes.
Okay. Any abnormal features which you would be worried about on the ultrasound and in the FNAC?
Didn't get you, sir.
Regarding, sir,
In the ultrasound, any other abnormal features, lymph node, for example, or extrathyroidal extension, are you not worried about all these things? Did it
yes,
show
sir.
anything?
Did not show, sir.
Should you not mention that? It's important, no? No,
Yes.
radiologically, no notes and no extrathyroid, because extrathyroid extension is a part of the staging process. Previously, the AGES and AMI score and MACHI score, all of them have been given up in the form of AGCC 7th edition. I think the classification that indicates the inclusion of extrathyroidal extension as one of the important features in addition
Yes, sir.
to presence of lymph nodes. Okay, what will you do for this patient now? Is the patient fit otherwise? Diabetes,
Yes,
hypertension, all controlled?
yes, sir. Patient is fit for surgery.
Okay, what will you do?
Total thyroidectomy, sir.
Why total thyroidectomy? Why can't you do the right hemithyroidectomy?
According to ultrasound, doesn't
Papillary
show any
carcinoma.
features in the left lobe, right?
Yes, sir. Only
Why not
right lobe.
hemithyroidectomy?
Meds to left lobe is more common papillary, sir. Other lobe.
If the size was
So,
less than 4 centimeters, we would have considered, sir, if it was unifocal in one lobe. But as it is 4 into 4 centimeters, chances would be high.
Age,
It should be in high risk group.
age also.
Age.
So is the age is one significant factor in this lady?
Yes, sir.
yes, sir.
So still I think with papillary carcinoma, you still be right if you say I'll do a thyroid lobectomy TL instead of TT. But what is your argument for total thyroidectomy and against? You have to be able to justify why are you offering total thyroidectomy.
Due to patient's age and size of the tumor, sir.
And what is the other important thing? Though the scan does not show it.
Micro mets can be present, sir.
Micrometastatic and micropapillary carcinomas. So,
Yes, sir.
papillary carcinoma is notorious to have multifocality, multicentricity. So, on that count and age, it's likely to be a more aggressive tumor. So, in size, 4 by 4 centimeters. Anything 1 to 2 centimeters, up to 2 centimeters, you can consider doing a total lobectomy rather than a total thyroidectomy. 2 to 4 centimeters, is a gray area where all other features you have to take into consideration before you do either TL or TT. But beyond 4 centimeters, it is generally accepted that you do a total
Total
thyroidectomy.
thyroidectomy.
Niranjan? Hello?
Yes, sir, I agree.
Subhash?
Yes, sir.
Okay. Now, what about the lymph nodes? What are you going to do? Total thyroidectomy. You are going to do total thyroidectomy. What are you going to do with the lymph nodes?
There is no clinical and radiologically involvement of lymph nodes, sir. So dissection is not required, sir.
Is that the classical teaching?
What is the central nodal clearance?
Prophylactic.
Clearance of level 6.
From where to where?
So, level 6 includes pretracheal, prelaryngeal, and upper mediastinal flows.
No.
Nikita, would you consider doing a lymph node dissection in this patient?
Sir, prophylactic is there as per the guidelines in case of advanced tumors only, sir. Like if it is T3 or T4, in that cases we have to consider doing a prophylactic central compartment neck dissection.
On one side or both sides?
So, central is
You bilateral.
in
Level
bilateral.
6.
Bilateral central, yes, sir.
Level 5 or only level 6?
Sir, level
Level
6,
6,
sir.
Level 6. No,
One
I'm
is
just
not involved, only 6, sir. Prelaryngeal, pretracheal, and paratracheal.
okay. So quickly describe the surgery, Praveen.
Transverse crease incision.
No. You don't start with transverse crease incision. What anesthesia, position, who's going to tell all that?
Yes, sir. Patient in general anesthesia in rose position, that is neck slightly extended and extension below the kept at the shoulder level, and a transverse skin crease incision is given at lower part of neck. Subplatysmal flaps are raised, and incision strap muscles are divided.
Why do you want to divide strap muscles? Not a large tumor, no? Why do you want to divide strap muscles?
Lateralized, sir.
See, where do you make the incision after you have raised the subplatysmal flap?
In the median raphe, sir.
Midline incision.
Midline incision, yes, sir.
Vertical midline incision of the general investing layer of the cervical fascia.
Cervical fascia, yes, sir.
So after that, you expose the strap muscles are cut if you feel that they are coming in the way. Otherwise, you don't unnecessarily. If you divide the strap muscles, where will you divide them?
So lower end, sir, near
Why?
to clavicle. Due to the nerve supply, sir. Ansa cervicalis.
Okay, good. So you don't divide the strap muscles unless necessary. You then dissect the thyroid. So what is the first step in when you are dissecting the thyroid? What is the first structure you deal with?
Middle vein, sir.
Middle thyroid vein.
Middle thyroid vein, sir.
Yeah. Okay.
Then
what do you do?
Ligation of superior thyroid artery near to the pole, sir. Upper pole.
If possible, identify the superior laryngeal nerves or external nerves and make sure that you preserve them. And generally, it is accepted to ligate the upper pole closer to the gland. Okay, then you continue the dissection. What do you do after that?
At the inferior pole, inferior thyroid vessels should be ligated separately, sir.
The branches should be ligated separately because
it can injure the recurrent laryngeal cell, ligate articles.
Previously, they used to say you ligate it away from the gland. but it is now accepted that you identify the individual branches and ligate them
Branches.
separately, because the nerve can intersperse with the branches of the
Branches.
thyroid artery.
Yes, sir.
And what are the other things, in this case, do you preserve the parathyroids, or do you have to sacrifice the parathyroid?
We'll preserve the parathyroids.
How do you do that?
So, parathyroids can be taken out and can be preserved in brachioradialis muscle, sir.
Or
If other is on the sternocleidomastoid, sir.
okay. Or can you just leave it behind in the thyroid fossa itself?
If it is identified, can do, sir. If it is blood supply is intact, we can leave it, sir.
Okay. Then what do you do? After you have dealt with both the poles, how do you proceed?
So, then identifying the recurrent laryngeal ulcer and preserving it.
When you are doing the lower pole, you will obviously identify the recurrent laryngeal nerve.
And
what are the points in Nikita? What are the points in identifying recurrent laryngeal nerve?
Sir, the main point would be the tracheoesophageal groove, sir, most commonest. And the other commonest along with the inferior thyroid artery. And in between the both parathyroid glands, sir, as a percentage symbol.
What?
In between the two parathyroid glands, sir.
You said some symbol. What symbol?
Percentage.
What do you mean by percentage symbol?
Sir,
The nerve goes
flash,
between the
yes,
two glands. Okay.
Yes, sir.
Okay. I understood now. Okay. What is organ of Zucker candle? What is its role in identifying the recurrent laryngeal nerve? Why are you silent? No role?
There is a role, sir. It is seen crossing the
Homework. So I think you are still not sure. Everyone knows about the tracheoesophageal groove and the inferior thyroid. So you should know because that is one of the questions they will ask you, all the pointers towards the recurrent laryngeal nerve, and occasionally non-recurrent laryngeal nerve also. What is the percentage of non-recurrent laryngeal nerve?
about 10%, sir.
No, that is too much. Again, homework. Put it up in the group. So after that, you have to go towards the isthmus, dissect the isthmus, and then repeat the same procedure on the left side. Then while you are doing this one, after you have done that thyroidectomy, you do the central node dissection. So what do you mean, Nikita, by central node dissection? How do you do it? Did you watch Professor Vijay Kumar do it?
No, sir.
Who assisted the surgery from our side?
Me and Aina, sir.
Then didn't you watch what he did?
Sir, only total thyroidectomy was done, sir.
He didn't do a neck dissection?
No, sir. No, sir.
Subhash, central node ಮಾಡಲಿಲ್ವಾ? Hello? Subhash has left?
Yes, sir. Sir has left.
But with that day Vijay Kumar, I recollect him saying that he did central node dissection. He didn't do it, Ainas?
I was also
No,
there. Sir
sir.
told that he did central dissection,
Yeah, that's
central
what
clearance.
central node clearance.
No, sir.
No, sir.
Yeah, 100% sure because uh, the mass was very firmly adherent to the trachea and with very huge difficulty, sir has separated, sir. Post that, no separate dissection was done.
Okay, right. Niranjan, any questions so far?
I think so. You have to do routinely central node dissection?
It is prophylactically advisable only in the advanced tumor, sir.
No. What do you mean by advanced tumors? You can't say
Advanced tumors,
advanced or
that's what you. What are the things which will tell you that you may have to do it?
Sir, as per literature, it is T3, T4 lesions. So depending on the size, more than 4 centimeters, it would be advisable to do, sir.
Then why
Ours,
didn't you do it in this
even
case?
when radiologically it is negative?
yes, sir. Yes, sir. Even when clinically and radiologically, if there are no lymph nodes, but if it is more than 4 centimeters, it is advisable to do a central neck dissection, either ipsilateral or bilateral, as per the choice.
That may be a controversial thing. Sir, is there clear-cut guidelines? I don't think so.
Though I think you have to have all these features like extrathyroidal extension, all these things. Those are those are the points that will dictate whether you need to do prophylactic nodal dissection or not.
High risk
What
group, yes.
what are the complications of central compartment clearance?
Nerve injury.
Nerve injury, then what else?
More than nerve injury, something
Right.
else is more common.
Kylie, sir.
Huh? What is that? Praveen, you said something.
He told Kyle leak, sir.
Kylie, sir.
Kyle
Thoracic
leak.
duct injury causing.
How common is it?
Why should it cause more than that? What structure
Where
are you
does
on?
the thoracic duct comes there? What is the main thing in central compartment clearance? What are you scared of?
What is the
Parathyroid.
important?
Yeah,
Parathyroid.
Parathyroid.
hypocalcemia.
So I think I think we need to go back, and I am also, though I had actually read, it is sort of disappeared from my. So we need to go back and check when is, see, these things, it's constantly evolving. That because they're going less and less radical now with thyroid compared to what they were
Because
doing before.
even like nowadays they say even if you've done hemithyroidectomy, rest of the gland can be taken care if
Yeah,
pre-op diagnosis is not sure by a non-operative management.
correct.
So it
So
can be wait and watch, which can be radioiodine therapy or anything else like revision surgery also. But that's what less and less, as sir is mentioning, we are going for less and less radical.
radical surgery. So
So
that is why
just because
nodal
it is a 4
dissection
centimeter
also.
tumor, you cannot say that it is a high, you can say that it is a high risk candidate. That's why I'll do prophylactic central clearance.
I think we'll go back. I think all of you go back and read. I think I had read it when I took the class, but somehow I'm not able to recollect. So we'll have to go back and read that. But the general trend, as Niranjan and I have told you, see, total lobectomy is acceptable for papillary carcinomas now. And of course, total thyroidectomy is the other option. And so those are the only two surgeries now. All other things are all given up. So don't say subtotal and near total, all those things. Only two things are there: total lobectomy, total thyroidectomy. Only two surgeries are now accepted. And you can argue both ways that if you want to do total thyroidectomy, you should tell them why you want to do total thyroidectomy. If you want to do because what you have to understand is, even if you do a thyroid lobectomy if there is evidence of recurrence at a later date, the prognosis does not deteriorate. The patient will have similar 5-year, 10-year, and 15-year survival, despite waiting for any new tumor or tumor that was probably present as a micro papillary disease to manifest as a clinically relevant tumor. And even if you operate at that stage, this one long-term disease-related survival will not be affected. So for that reason, because
And also, if you have done total thyroidectomy and where radiologically there is no evidence of any metastatic disease in the lymph nodes, radioiodine, post-operative radioiodine, you will invariably do, and that can take care of the small minute nodes if it is there.
Yeah. So the thing is, because total thyroidectomy, increases the chance of two major complications. One is recurrent laryngeal nerve, and second is the parathyroid hypocalcemia. What is Nikita? What is the percentage of permanent hypocalcemia in patients with total thyroidectomy? Permanent. I'm not talking about temporary. You can tell me about temporary also.
Permanent is around 5 to 10%, sir. Temporary, I'm not sure, sir.
Praveen?
Not sure, sir. Temporary. I'll find out soon.
Ainas, do you remember?
No,
Samir?
no.
Samir? Nitya or Sanya?
Transient would be more than that, no, sir.
No, that is, it is a logical thing. Nitya, what is the percentage of temporary hypocalcemia, temporary hypoparathyroidism, and permanent?
I'm
Nitya
not,
there?
I'm not exactly sure, sir.
Sanya?
Sir, permanent is around 1 to 2%, sir. Temporary would go up to
That is
25 to
very
30%,
less. That is
1 to 2
very
is
less.
too less. I
It's
think what
around
Nikita,
approximately 10,
10%.
but some
yes,
literature it has gone as high as 13%. So it can vary between anywhere between
7 to
10%, but
13%.
across board it will be around 10%.
10%. And temporary will be up to 25,
20
even
to
30%.
30%.
It
Yes,
can
sir.
go as high up as a 40 to 50% also, but across board around 30%.
So, Nikita,
Yes,
what
sir.
is the mechanism of temporary hypocalcemia? What is the mechanism of
And the
permanent
rates
hypocalcemia?
go up if you include a central clearance along with total
Yeah,
thyroidectomy.
correct.
Sir, during the dissection, if there is any devascularization or just the vasoconstriction to the vessel supplying the parathyroid, it will cause the transient, sir. But in case of complete devascularization and removal of ex mm,
Parathyroid.
excision or removal of the parathyroids will result in permanent.
So depends on the number of glands there are.
Yes, sir.
And as Niranjan said, if you have done a neck dissection as well, central compartment dissection, the chance of permanent hypocalcemia goes up. So for these reasons, it is frowned upon now doing all this unnecessary radical surgery, because the cancer registries across the globe has shown that papillary carcinoma and even follicular carcinomas behave much less in a malignant fashion compared to what they had thought of. So which is why now the trend is to do less radical surgery. So that is why you have to be careful about these things. I think other thing is, what is the most dreaded complication of total thyroidectomy, Praveen?
Hemorrhage, sir.
One is
Primary
hemorrhage,
hemorrhage.
second one.
And reaction.
What is the second one?
Nerve injury.
Nerve injury, sir. Recurrent laryngeal nerve palsy.
No,
Bilateral
nerve
recurrent laryngeal
injury,
palsy.
you can't say nerve injury and get away with it. You have to be proper.
Yes, sir. Bilateral recurrent laryngeal nerve palsy.
So what will it cause?
Sir, it causes stridor and respiratory obstructions.
respiratory stridor and respiratory obstruction. So that is a dreaded complication. So bilateral recurrent nerve injury causing stridor. You should be very clear about this. Hemorrhage
Yes.
and bilateral recurrent nerve injury causing stridor. So you have to say that. Those are the two dreaded complications. Okay, now you have done a total thyroidectomy, and what is the next step in this patient? How do you monitor this patient? What will you do? What are the indications for giving radioiodine therapy? Hmm?
Usually after
All
4 weeks of withhold of
No.
four
First
four
tell
weeks
me what
post
are the
surgery.
indications for radioiodine therapy. Then you tell me when to do it, how to do it. You thought thyroid is easy, no? Thyroid, and as Niranjan keeps telling all of you, inguinal hernia, thyroid, and breast, they will always be there. And if you don't answer these questions properly, then you are likely to fail. Nikita, what are the features on histology which will prompt you to consider radioiodine therapy?
Sir, capsular invasion and lymphovascular invasion, and all the cases with extranodal extensions will require
Not extranodal, extrathyroidal extension.
extrathyroidal
ETE.
extension.
ETE. And then extrathyroidal extension is one. Size is
Greater than
another
2 centimeters.
4 centimeters. 2 centimeters if there are very, bad features on the histology, like the differentiation, presence of multiple microcalcifications, and as you said, lymphovascular invasion, all of these features.
Lymph node, yes, sir.
And then presence of multiple lymph nodes, more than 4 lymph nodes being involved. So these are the indications for giving, radioiodine therapy. So now tell me, how do you do it? Praveen, will you tell us, or
So it should 4 weeks of nil supplementation should be there. Clear giving of
not called
radioiodine.
supplementation. What is it called?
Starvation.
Basically, you don't give them Eltroxin or Tylenol. So basically, what is the purpose of doing that?
To hyperstimulate the remnant follicles. To
So
take
the TSH
to
should be,
uptake of iodine, sir.
what
Greater
should be
than
that
20, sir. Greater than 20, sir.
Preferably nearer the 40 mark. So the idea is, if there are, you make TSH so high that if there are any radioiodine avid nodules elsewhere, it will be picked up by the scan. So that is the purpose of starving the thyroid. So then, if it is available, iodine 123 scan, but in India it's not available. So what you do is a low dose iodine 131 scan.
131 scan.
So once you do that, if any nodule is picked up, then you give the therapeutic dose. What is the therapeutic dose of radioiodine? Any idea?
250.
Huh?
250
How much?
microcurie. 250, sir.
Is it microcuries or backvirals?
Microcurie, sir.
Microcuries.
250 now. I think
Yes, sir.
250 is too high. I think the radioiodine dose is in backvirals. You can even give up to 200 backvirals in very high decibel. Otherwise, generally up to between 50 and 100 is what is given as a therapeutic dose. And when do you repeat them? After what interval do you repeat to see if there is any residual nodule? What are the other parameters that you monitor to see if there is recurrence?
We can monitor the
Ultrasounds.
TSH.
Ultrasounds.
No, what TSH, man? You want TSH to be very low. So you are giving them suppressive dose. Again, in the first few years, you make sure that you give very high dose, that is between 150 to 200 micrograms of Eltroxin or Tylenol, so that the TSH remains less than 0.001. After 2 or 3 years, now I think Swaroop told me this, you have to check the literature that you are now permitted to reduce the dose of TS, the T3, T4, so that the suppression doesn't have to be that potent. So just check the dose. And usually the radioiodine is repeated after 6 months. Other thing that you monitor is thyroglobulin. Why are you not answering properly? Thyroglobulin is another thing that you monitor regularly. So the two things you have to monitor in patients who have undergone total thyroidectomy is thyroglobulin to look for recurrence and TSH to look for the level of TSH, so that you can adjust the dose of Eltroxin or Tyronol. And after 6 months, if there is no recurrence, then you just monitor them. You don't have to do repeated radioiodine studies. You just monitor using thyroglobulin. And if the thyroglobulin level goes up, usually goes up much before there is any clinical or radiological evidence of recurrence. So that is why thyroglobulin is a very sensitive, prognostic indicator marker. So you use thyroglobulin, but if you have given radioiodine therapy, you have to check after 6 months to see if there is any recurrence. Okay. So I think fairly.
So we are repeating thyroglobulin after 6 months, sir, the first time?
No. Thyroglobulin has to be repeated after 3 months.
3 months.
That is, if at all you have not, whenever you consider radioiodine, at least you have to do after total thyroidectomy for malignancy, you will have to do radioiodine studies anyway, because obviously if you are doing a total thyroidectomy, that means that there are features which are which dictate the surgery to be total thyroidectomy. So at the end of about maybe 8 weeks or so, your TSH will have gone up between 20 and 40. Then you do radioiodine studies. If the radioiodine studies do not indicate any presence of any residual disease either in the thyroid or in lymph nodes or elsewhere, then you don't have to give them ablative therapy. Then you start them on high dose suppression with the Eltroxin or Tyronol, and then you monitor TSH every month till you have attained a TSH level less than 0.01, and then at the end of 3 months after the starting of the treatment, you do a thyroglobulin, and at 6 months you do radioiodine again if you have ablated. If you have not ablated, you don't have to do radioiodine again. Then monitor every 3 months in the first year. After that, you can monitor every 6 months.
Okay, sir. Yes.
Okay, right. Any doubts? Niranjan, comments?
No, sir.
So nothing else, sir. You have covered everything.
So I think all of you go and brush up certain doubts that we have raised. You have to clarify them. And some of the questions that you didn't answer, you have to answer in class, in our WhatsApp group. Okay.
Yes.
And
Yes.
all of you go and read up again about thyroid malignancies, about the features which warrant present, neck dissection, all these things. Okay, right. So if there are no further questions, we'll stop. Good night.
Good night, sir.